So by that time, we'll be ready to um, um, divide ourselves into three main rooms, and I will also give you the instructions. And then after the breakout room, we have a lunch break. After lunch break, we come back into the breakout room again, and then we have an afternoon break. Again, depending on how we are progressing on the agenda, the afternoon break can be adjusted and making sure that we are still alive, breathing, but also focused on the reason why we are here today. Then in the afternoon, we have a panel discussion with UNICEF and WHO on sustainable HIV response with religious leaders, advocacy, including through leveraging on the Rome Action Plan to end pediatric and HIV and TB. We also have Margaret from PATA on integrated HIV service for children, adolescents, and young women, experience of PATA and youth care project in Kenya. We have a panel after the presentation, and then we will finish by a quick briefing from our colleagues at GNP+, and then that will be the end of the day. As you can see on the agenda, we are aiming to finish by 15 minutes past 5. So this is the milestone, and I think this is going to be our collective responsibility to track time, and we make sure that everyone manage their own agenda. We know that we also have other responsibility beyond this one, so we make sure that everyone can adjust the agenda according to this one. So without further ado, I know presentation or introduction will be great, but we are 50-ish people. It will take us a lot of time. So we will use the break and the lunch to hug and share, and also whenever you take a mic to introduce, please introduce yourself so that everyone knows who is in the room. One last remark from my side is that we kind of had some of this presentation yesterday, and some of them are really mind-blowing. So it require us to be ready to be challenged in our way of thinking, also way of doing things. We are not in normal time. That's obvious to everyone. So please, as we hear from the presenters, note your questions and also try to help us to think through how do we go from here today. We don't, someone said yesterday, the past is the past, now is now, we need to look into the future. So Jeff is ready online, who is our first presenter. Our IT team, if you can. In the meantime, please, if you need anything, any support, any question, you can, I mean, at individual level, you can come to me or come to any GNP Plus colleague sitting there in the corner, and then we make sure that we support as much as we can. IT, is the online people ready to? No problem. I can. Yeah? Okay, thanks everyone. I think we are aligned with technology at the moment. I think we are ready to start with people online. So just a quick reminder that we said we have the three presentation. I will give you 2 to 3 minutes to write down your question after each presentation so that we can have the Q&A after all the presentations. Helen, are we ready? I just want to say hi to Jeff so that we can test the sound.
Hi, can you hear me?
Yes, we can, but we cannot see you yet.
Great. I've got my video and I've got my slides on. Are you seeing my slides on the screen share or?
Only in Zoom right now.
Jeff, we can see you both we can see your slides on Zoom and we can see you on Zoom as well.
Yeah, it's
I'm not in the room, right?
yeah, it's not only in the room. Just give us a second. We'll fix this.
Okay, okay,
Yeah,
okay,
yeah.
cool.
Okey-dokey. We can see you. Now we can see you, Jeff. Can you test the sound again?
Yeah.
Wonderful.
Can you hear me now?
Yes.
Wonderful. Are the slides working there or? Cedric, just checking, are you hearing me still?
Yeah, we can hear you. I think they're trying to put those slides.
Got it.
Yeah. It's looking very good, Jeff. We can see the slide. We can also see you. If you can start with just a brief introduction and then go with the presentation. Thank you.
Great. Thanks very much, Cedric, and thanks everyone for the invitation this morning. I'm going to start our session this morning talking about sustaining HIV epidemic control beyond 2030, what data and mathematical modeling tells us about responding to an evolving HIV epidemic. And I should start with perhaps a couple of disclosures about myself, perhaps relevant to our meeting. Firstly, I'm not living with HIV. Secondly, I'm an epidemiologist, so these are probably a couple of things that we need to think. Maybe I don't understand the world and fully in some ways, but what does this mean? So we study HIV as an infection that is transmitted between individuals. Some people and communities experience disproportionate risk of acquiring HIV or adverse health outcomes from HIV due to multiple biological, individual, structural factors. And we can use this information to devise strategies that optimally use available resources to ensure the health of individuals in our communities for long periods to come. And that's what we mean when we talk about controlling the epidemic. And often this involves math. I should also disclose Florence has become one of my most important role models and mentors, and so when Florence asks you to do something, you sort of say yes. key messages that I'd like us to take from our start here today is firstly, to put us in a mindset of thinking long term. I think whilst we're all very focused on short-term challenges and on reaching progress and milestones over the next few years, the global community will be living with HIV for decades to come, and we need to collectively shift our focus to activities that establish systems for decades of sustained and resilient HIV epidemic control. And secondly, to really remember and communicate clearly that from an epidemic perspective, effective treatment and U equals U is really the cornerstone of both long-term health for people living with HIV and for sustained epidemic control. There's lots of things we need to be thinking about and doing in terms of the HIV response, but we need to keep this front and center and clear to everyone that effective treatment is the foundation that all of that is built on. For an outline, we're going to speak briefly about global progress towards the 2030 goals and targets. Also look at how some of that progress has diverged across regions and varied epidemics, and then talk about sustaining effective testing, treatment, and prevention programs over the short and long term. So first, regarding the situation with the global HIV response, we have had very sustained progress for almost 2 decades now at both reducing new HIV infections and reducing AIDS-related deaths by 39% and 51% respectively. And this overall success has been really built on the remarkable HIV testing and treatment across all regions of the globe. We really shifted the situation over the past 20 years in terms of the majority of people living with HIV being diagnosed and on ART and virally suppressed now. However, that progress hasn't been fast enough. We're lagging substantially behind where we want to be with respect to our targets for reducing new infections and AIDS-related deaths by 2025 and 2030. Our progress is also diverging across global regions. Almost all of the changes in new infections from 2010 to 2023 have been in the Africa region, where new infections have reduced by around 53%, and we've seen almost no change in the estimated total new infections outside the sub-Saharan African region. And we now estimate equal numbers of infections outside the Africa region as within the Africa region, a really marked shift over the last 15 years. We can see, again, we can look at regions in somewhat more stratifications in terms of progress. We see there are around half of infections in Eastern, Southern, and Western Central Africa, where infections have declined by a bit more than half. Then other regions, Western, Central Europe, Caribbean, and Asia Pacific, where infections have declined, but somewhat more slowly. And then some regions, Latin America, Eastern Europe, Central Asia, and the Middle East and North Africa, where we estimate that new infections have actually increased over the last 15 years and seeing real lack of progress. And broadly, the progress that we're seeing is very correlated with the success at scaling of testing and treatment and suppressed viral loads across regions. Now, of course, representing regional trends masks a great deal of variation and heterogeneity within our regions and programs. And so, for example, if we look in Southeast Asia, we see really stark contrast between Malaysia, where they've implemented very effective programs to reduce and almost eliminate new HIV infections amongst people who inject drugs over the last 15 years, compared to the Philippines, where despite having really quite strong surveillance and monitoring, new HIV diagnoses have increased really dramatically without any sign of abating. And I think the main message here is to emphasize that the reason that we're struggling and to make progress in some epidemics compared to others isn't because we don't know how to control HIV or we don't have the tools available, but rather it's the circumstances and commitment to responses that's holding us back in the places. So it's not that we don't know what to do, it's challenges in implementing and doing that. If we look at our Eastern and Southern Africa region, where we made the most progress in rapidly scaling up treatment and viral suppression, we see even further that in sets of countries that have attained the 95-95 reducing new HIV infections. So seeing even greater reductions of 70% in above and new infections, putting the targets to reduce infections by 90% by 2030, potentially reach in some of these countries. Again, telling us that we now have a blueprint and a roadmap for how to be successful in responding to and controlling HIV. It's also important to recognize that the population living with HIV is really dramatically changing as we're seeing as we respond to the epidemic. So we look here over 2010 and 2030, and projecting forward to 2050, that the median age of people living with HIV has changed really dramatically, increasing by about 15 years since 2010, and that's going to continue increasing. We can also see that the people who have unsuppressed HIV infection and the composition of that population has changed dramatically as we've scaled up 1990 and the overall population has aged. In 2010, when we started our programs, people with unsuppressed HIV were very much concentrated or disproportionately in the young adult age group, kind of between ages 20 and 39. And we can see that now with 2030 and projecting forward to 2050, people with unsuppressed HIV are firstly far fewer due to the progress that's going up, treatment and attaining 95, but also spread across a much wider age range. So there's still young people living with HIV, but many proportionally more aging and older people living with HIV as well. And so this has important implications that we need to be thinking about for HIV care packages. Who are the untreated populations that we need to reach with HIV testing and linkage to care, and who are those who are at risk of needing at risk of acquiring infection who need HIV prevention. We can also see really clearly that as we reduce new infections and increase treatment coverage and viral suppression, the hotspots are harder to find. This is an example of Malawi, where we look at the proportion of the entire population with viremia with unsuppressed HIV infection, and we can see that there's very clear hotspots of infection, but overall, over time, the hotspots blend in much more, meaning that it's going to be much harder to identify and narrowly target specific locations and populations. Also going to speak briefly about AIDS mortality and advanced HIV disease. We made very rapid progress initially at reducing AIDS-related deaths, but have some concerns now that progress is slowing at reducing AIDS-related deaths. And if we look at where we estimate amongst two AIDS-related deaths are occurring in 2023 globally, we estimate that around 40% of AIDS-related deaths are amongst people living with HIV who are not on ART, highlighting the need to continue to strengthen HIV diagnosis, linkage, and prevention. But 60% of AIDS-related deaths are amongst people living with HIV who have initiated or are on ART, highlighting also simultaneously the need to improve timely initiation, care quality, and treatment effectiveness if we're going to continue reducing excess deaths related to AIDS. And I think one really striking and concerning feature of this scenario where WHO have compiled a great deal of data recently along with others is that whilst initially the proportion of people initiating treatment with advanced HIV disease and those programs declined really rapidly, we've now over the past decade really seen that stagnate. So in all global regions, between 25 and 40% of people initiating treatment are initiating treatment with advanced HIV disease with relatively minimal progress since 2015. Now moving forward and looking at what can we do to accelerate progress at reducing new HIV infections. So first of all, now focusing on Eastern and Southern Africa, where we've had the highest attainment in scaling up testing and treatment and reducing new infections. If we maintain current coverage of both treatment and prevention at levels we have in 2024, we estimate there will be around a 17% further reduction in new infections by 2030. So new infections will continue to decline if we can maintain current programs and coverage levels. If we're able to accelerate progress and all countries in the region were able to reach 95 by 2030, we could reach to attain all of the global AIDS strategy, treatment, and prevention targets, so 95, 95, 95, as well as relatively ambitious HIV prevention targets, we can reduce new HIV infections by almost 90% by 2030. And then if we look forward to what happens beyond 2030, and whichever of those trajectories that we're on, if we're able to then further maintain coverage at high levels beyond 2030, new infections will continue to more slowly but steadily decline up to 2050, and we'll really be able to continue driving down new HIV infections for several decades to come. However, the important thing to recognize is that under all of those scenarios, even if we're able to really rapidly reduce new HIV infections, people living with HIV are going to survive for many, many decades into the future. So even if we get on the most rapid trajectory there are new infections, we're going to have between 13 and 17 million people living with HIV in Eastern Southern Africa for decades to come, needing comprehensive care and treatment services, and we need to be communicating that very clearly, that continues well beyond 2030. And then the last thing to close here is thinking about what do we need to be thinking about in terms of HIV programs into the future. And I think there's a very reasonable question that many of us are asking right now in settings that have been successful at scaling up programs and reducing new infections. Are we able to start thinking about reducing or scaling back some programs in the future? And so we looked here at doing some very long-term projections of the HIV epidemic in South Africa up to 2100. Firstly, looking at what happens if we maintain current program coverage levels of testing, treatment initiation, condoms, voluntary medical circumcision, and oral PrEP for high-risk populations. We see that under that scenario, new HIV infections in South Africa are projected to continue decreasing for a very long time into the future, reaching eventually very low levels. But so we asked the question, what happens if we were to think about from 2025 onwards, start scaling back some of our interventions? So what happens if we continue our current HIV testing and treatment interventions, but discontinue other prevention from 2025 onwards? If we were to discontinue pre-exposure prophylaxis amongst female sex workers, men who have sex with men, and high-risk adolescent girls and young women, we see that new HIV infections do continue to decline into the future, but they stabilize at a somewhat higher level, so we never reach the very low level infections due to persistent ongoing transmission and infection amongst the high risk, the populations at highest risk of acquiring infection. If we were to discontinue PrEP and voluntary medical circumcision, again, infections decline, but stabilize at a level above our 1 per 1,000 threshold that we hope to reach. If in addition to that, condom usage were to, in the wider population, were to reduce by 15%, we see new infections stabilizing at a relatively higher level. And if condom use reduced by 30%, in addition to discontinuing prevention, new infections in South Africa could potentially stabilize at similar levels to what we have now, stagnate, which I think we would all collectively see as a very successful outcome. What if we were to attain 95, 95, 95? Attaining 95, 95, 95 could help us to accelerate the declines in new HIV infections by rapidly increasing viral suppression and reducing viremia in the population. But if we were to attain 95, 95, 95 and discontinue PrEP and circumcision coverage, we still get that rapid reduction in new HIV infections, but incidence stabilizes at a higher level in the long term. And lastly, I think just thinking about this scenarios that we're concerned about here, this reduction in condom usage and prevention isn't necessarily theoretical. We look at condom distribution data from South Africa. Indeed, male condom distribution has reduced by around half since the peak in 2016, 2017. And then lastly, I think the proverbial elephant in the room that we're all thinking about and very mindful about is if we were to simultaneously see a reduction in condom usage as well as reduced HIV testing and ART coverage by only around 10%, that could send new infections back to increasing and really start reversing the progress that we're seeing in the HIV response. So just to close, some HIV program priorities to sustain HIV epidemic control. Firstly, effective treatment really is the cornerstone of success, so we need to collectively be focused on maintaining extremely high treatment coverage, retention, and undetectable viral load. And I think this is really powerful, the alignment of individual health outcomes and epidemiologic outcomes through U equals U. Second, continue to focus on timely diagnosis in order to route infection and limit opportunities for HIV transmission. Thirdly, adapt HIV prevention. I think we should anticipate that individual needs, motivation, or preferences are going to evolve, and we need to meet people with a prevention package that meets those needs and will not allow new infections to increase. And thirdly, lastly, key population service, the importance of maintaining prevention services to meet the distinct needs of populations sustained in perpetuity. So I think in closing, we should start thinking about phasing out language referring to the end of AIDS, but really focusing on a long-term resilient HIV response and focusing on activities that establish systems for decades of sustained epidemic control. Much of this work came out of some consultations that UNAIDS convened over the last couple of years, and I know many people in the room there today indeed were a part of and contributed to. There's more on some reports in this commentary summarizing the results of that, and to acknowledge a very large number of people who have contributed excellent data and mathematical modeling to the work we've seen here today.
Thanks so much, Jeff. Really mind-blowing. We're going to move on with the next presentation, but I hope you have some time to stay with us so that we can give an opportunity for questions after. Can I get your consent?
I'll be here.
Cool, thanks. So as I promised, maybe you take 2 minutes while we get Dr. Mumbi to come on stage. Write down your question, and then we make sure that all the questions are answered before the end of this session.
Right, while we do the connections and stuff, good morning, everyone. Yes, my name is Mumbi Chola from the Africa-led HIV Control Working Group based in Zambia, in Lusaka. Our secretariat housed at the Center for Infectious Disease Research in Zambia. I'm here to talk about our thinking as the working group about what we think it will take to sustain or to have a sustainable HIV response towards 2030 and beyond, considering the current context that we're in or the current funding environment. A few disclaimers as well, taking a leaf from Jeff. I've only been working in the HIV space for a very short time, probably like 2 years or thereabouts. So I'm here to share, as much as I'm here to share, I'm here to learn from the experts in the room who've been working in the field for much longer than I have, and also have lived experiences that I do not have, being a person not living with HIV. And some of my slides I borrowed from Jeff. We have had several conversations, me and him, and like he said, when Florence calls, it's very difficult to say no. So here we are. So Jeff did highlight that we've made a lot of progress since the early 2010s or 2000s as far as reducing infections and deaths associated with HIV. And during that period, we've managed through treatment scale-up, testing scale-up, and so on to achieve very good progress as far as the 95, 95, 95 targets. And all this has happened in the context of heavy donor financing. So we've received a lot of support from the Global North to help us get to where we are today. And with the funding coming from the Global North, to a large extent, the agenda has also been kind of shaped by the Global North. And one thing that stood out to me is that all the innovations and research that has been driven by the North has been done in Africa, which bears the largest burden of HIV, but then the translation of the innovations that come from the research that is done in Africa, there's been quite a lag between the implementation of that innovation in the North compared to down here in Africa. So, for example, ART took about 10 years between it being initiated in the North and being implemented in Africa. And if you go down the different innovations, you can see in the column on the far right that we've had quite a huge lag in between implementation in the North and down here in the South. And currently we are looking at issues around long-acting PrEP, trying to get it to be scaled up on the continent. So much as we have achieved all this amazing progress in as far as fighting HIV, we still have some challenges that remain. We have, based on 2023 data, about 23% of people who are diagnosed but are still not on treatment. We have significant disparities across the continent, across the different regions and countries. For example, in Eastern and Southern Africa, we still have about only 83% of adults on ART as of 2022. Coverage is much lower among children. If you look at Western and Central Africa, there are huge disparities in ART coverage in pregnant women. And in North Africa, the dynamic is a little bit different. I think over the period from 2010 to about 2024, we've seen an increase in new infections, particularly among key populations. In terms of where these, which populations are experiencing increases in new infections, the figure on the left is based on African in 2022, and we see that about 75% of infections are in the general population, whereas 25% are among key populations. And the reverse is what is reflected on the right. Outside Africa, we have only about 20% of infections in the general population, with the bulk of infections among key populations. In Africa, looking at data from FIA surveys that have been done between 2016 and 2019 across several countries, it's shown that new infections are most common in communities where we have high prevalence of unsuppressed HIV. So as we, with having high levels of unsuppressed HIV in some of our communities, that's where we are seeing quite an increase in new infections. And this tallies with other research that's been done. There was a study that was done in 13 countries, which showed that men who are unaware, untested, and virally unsuppressed were contributing quite a lot to new infections, particularly among adolescents and adolescent girls and young women. And about 33% of HIV-positive men were unaware of their status. Another study in Uganda showed that about 63% of HIV transmission in 2018 was due to lower viral suppression among men compared to women. So these are just some of the transmission dynamics that data shows from our context here in Africa. So where are we at the moment? January was a very life-changing moment for global health. We had the US change their policy towards foreign direct investment as well as funding towards HIV. We saw a lot of projects, after the executive order was issued, which were discontinued. PEPFAR so far has yet to be reauthorized and so on, which meant that we have a lot of funding gaps on the continent and beyond as far as HIV financing is concerned. So in thinking of going forward, we cannot do, it's no longer a business as usual kind of thing. We have to rethink how we finance and move forward in the context of these funding gaps. So how then do we figure out how to maintain the same level of implementation, but without all the external funding that we received? So just to highlight, we have received billions of dollars towards the HIV response, but then without that financing, which was discontinued early this year, we saw community health systems being dismantled. We had human resource shortages, commodity supplies and supply chain disruptions. We had data systems that were compromised. Some countries are still not able to access patient-level data and so on and so forth. So what then must we do to make sure that we have a sustainable HIV response? So we did publish, as the African-led HIV Control Working Group, a position paper or a comment in the Lancet where we put forward our thinking around what it would take to sustain the HIV response. And just to mention that we had these conversations well before what happened in January this year. I think we can all agree that over the past few years, there's been a flatlining in funding towards HIV, and conversations and indications, for example, PEPFAR being refinanced or reauthorized for a year for the first time in its history. Lessons learned from COVID, where the North prioritized their own populations before, the African populations and the rest of the world, particularly in low and middle income countries. And conversations with all these different funding agencies like PEPFAR, Global Fund, and so on. It gave an indication that funding was likely to start going down. Even in discussions with UNAIDS colleagues around sustainability planning and so on and so forth, it was meant to try and have African governments start taking more responsibility in the HIV response. So when this happened in January with US policy changes, it kind of brought forward, in our eyes, the timeline to the eventual or the inevitable point where we would not have as much funding from the global North. So there are about 6 key pillars that we thought would be essential for us as we try to sustain our HIV response. And the first was to strengthen political commitment. So HIV has not been at the forefront of the agenda. So we think it's important to bring back and strengthen political commitment towards bringing HIV back to the top of the agenda. We've had several commitments, for example, the Abuja Declaration, the Lusaka Agenda, and so on, that have been put forward and committed to by most African countries. But then there's been not much traction beyond that. So we think it's important that we go back to the drawing board and bring HIV back to the top of our agenda. We need to increase domestic financing. And this can be done through innovative approaches, for example, debt for health swaps, private-public partnerships, and various different funding models and mechanisms that we can think through and see what would fit best in our context for us to be able to generate domestic financing. And also, on the other side, much as we strive to increase our domestic financing, we need to be more efficient in how we use the minimal resources that we have. The third pillar, which I think, in my opinion, is one of the core or most important pillars, is to empower communities and prioritize equity. From inception, even from conversations yesterday with colleagues who've been with us since yesterday, communities of people living with HIV have been at the core of the HIV response, even before we had the scale-up in treatment and testing and so on and so forth. So we still need to have communities at the core, because in the communities is where the fight with HIV happens. So we need to make sure that communities are at the forefront of leading the response. We need to invest in research and data sovereignty. We need local data. We need ownership of the data that we collect in our context for us to be able to use this data to make informed decisions that will benefit our populations and our communities as we push forward to meeting our 2030 targets and move beyond to sustaining the response. We do live in a global village, so to speak, so we still need support from our partners. It's not that as we advocate for Africa taking the leadership of our response, it doesn't mean that we discard the support from our global partners. But we need to ensure that the support that we get from our global partners does align with our priorities, factoring in our experience and expertise on the continent and the direction that we want to take with our response. And lastly, we need to address legal and policy barriers because these border on access to treatment and prevention services. So we need to make sure we reform our criminalizing laws that perpetuate stigma and exclusion and contribute to driving infection. So we need to make sure that we have a rights-based approach in our health systems to ensure that everyone has access without discrimination. I think, so my last slides, I just wanted to talk about what is the HIV response without them. So for us, we think that a response that is not community-led cannot be truly sustainable. So the communities remain the cornerstone of the HIV response, both historically and going forward. So we need to make sure that we strengthen our voices and amplify our voices, even as we try and rethink our advocacy strategies, particularly with the changing dynamics of the push for governments to lead the response and integration and all that. So then how does our advocacy and ensuring that people living with HIV have a strong voice and a seat at the table in shaping and driving the agenda going forward? I'll end here, and thank you very much for listening.
Thanks so much, Dr. Mumbi. So I know you were here, so I'm going to ask people to write down the question, the 2 minutes as we agreed, and we made a little bit change in the agenda. We have Andy from WHO before, and then Dr. Nduku will come last. Can I ask people in the IT to connect Andy while people are noting down their questions for Mumbi?
Thanks, Cedric. Do you hear me okay in the room?
We can hear you. We are just waiting for the slide to be displayed on the screen.
Great, thank you. Let me know when you can see them now.
Yes, thanks.
Perhaps I'll just start off by saying I'm so disappointed that I can't be with you. I had planned to join you in person, but I got a respiratory virus at the weekend, and it's really knocked me, so I'm really sad not to be with you all, but I'm delighted to still be able to join you virtually. Great, you can see the slides now, I see.
Yes, please go ahead. Thanks, Andy.
Thank you so much, Cedric. So good morning, everybody, and thanks again for this opportunity. So my name is Andy Steele. I work for the WHO Department of HIV, Viral Hepatitis, and STIs. And what I'd like to do today is offer a rapid update. I mean, some of this has already been covered in the last two presentations, so I've already removed several slides from my presentation to make sure that we're not duplicating or repeating. But I'd really like to focus on some of the key innovations and relationships which are critical to our work moving forward. I'll say a little bit about some of the work that's happening around the global strategic frameworks, the two principal ones that I think are important to people living with HIV, recognizing that this is in everybody's interest in moving forward. I put in the reference to UN Plus here just to remind myself to say I've been living with HIV for 30 years, and I was a co-founder of UN Plus, which is the United Nations staff group of people living with HIV, founded back 20 years ago. Sadly, the UN is also hit by some of the changes, WHO, UNAIDS and others. So we are going through considerable funding cuts and some difficult decisions. So UN Plus may be paused for a little while, but we certainly hope we will be able to revitalise UN Plus once we've been through this period of readjustment. Global health sector strategies really align well with the global AIDS strategy, and essentially all you need to know is that these take us, they're comprehensive, they take us to 2030, and we have a mid next year where we can align what's coming out of the new global AIDS strategy. Positive network and the inputs of HIV positive people have been so critical to development and the assessment and monitoring of our work through both the global AIDS strategy and the global health sector strategies. So some of what I want to talk about today is also about the opportunity that, this crisis that we've suddenly found ourselves in is coming at a time where we can actually bring this together in a strategic manner to do some course correction around what we need to do, reprioritize, perhaps simplify our approaches, and also secure buy-in from member states as we do this. Some of the slides I'm presenting today, I presented on Thursday last week to member states in Geneva, and it was really fantastic. We had 70 member states turn up for this briefing, and we had fantastic inputs from South Africa and Zambia, very keen to make sure that we're being thoughtful about each. Obviously, we were in a more acute situation this year because of the funding cuts, but we were still going to struggle to reach our targets. And I certainly appreciate Jeff's suggestion that we shift our focus away from NDAs to really looking at control and moving forward with a new strategic vision that is perhaps a little more realistic. Many of those goals were really set up to speak to, let's be honest, the US audience. The US has been a fantastic funding partner over the years, but sometimes some of the global work we've done really has been largely focused on making sure we can shore up and secure funding support. And I think many of us from the positive community have questioned the realism of some of the goals that we've all signed up to. Like others, WHO, as you'll see on this slide, has worked with partners to work on modelling. This was some work we did with the Bernard Institute, which was published in the Lancet, I think, just last week, or perhaps the week before. And again, due to these new changes, we could see up to 10 million new infections by 2030, and perhaps 3 million deaths. So we are in a new emergency phase, I think, and we really need to be rethinking. So this meeting is very timely to help us do that. And again, I won't go into the details of this. You see the link on the slides. We'll make the slides available afterwards. But the key point from this slide is that recognizing that sub-Saharan Africa is most exposed to the international funding cuts. And I think that's where we're going to need to do a lot more work with government and with other partners to find ways to move forward. Since this emergency kicked off, WHO has convened a regular informal civil society reference group, as has UNAIDS, and we alternate our groups to really share intelligence and focus in on areas of importance. This group has recognised that our midterm review and the global AIDS strategy as well offer an important opportunity to really highlight and focus in on what is an urgent are writing to WHO to ask us to consider, not just for HIV, but for TB and other diseases as well, to call a public health emergency of international concern. Certainly, I think there is clear rationale and logic to declaring national level emergencies, if and as appropriate. And I think we shouldn't wait to see impact data. We shouldn't wait to see data on newborns with HIV or new infections or deaths. I think the service level disruptions should be enough for us to respond, certainly at the national level, and perhaps even at a global level, through the various signals that get discussed in our emergency functions at WHO. Communities are also asking international partners in the UN system to engage more systematically. Clearly, we're getting a lot more rapid intelligence from communities and community level monitoring around service interruptions and stockouts. And we need to make sure that we're bringing this into our ongoing monitoring. So WHO is going through some significant challenges. The US government withdrew from WHO on day one of the new administration, and that's led to us going through quite a severe process or a robust process of realignment and readjustment. So you'll hear news about that in the coming days. We will see significant reductions in workforce at WHO. But even though we're facing some of these disruptions, we are still pushing ahead with our key role, which is around the translation of science and innovation into guidance. And potential game changers are still emerging. So we've got an exciting few months and years ahead. And no surprises, lenacapavir is probably the first thing I'd like to highlight. Alongside other partners, we're working hard to make sure that the opportunity that we have through this long-acting injectable PrEP product is made available, and we do have opportunities to scale this up. So we'll see guidance coming out in July in Rwanda at the International AIDS Science Conference. That's a much more acceleration of this work as we move forward. As we look at innovation, we need to balance innovation and the potential for future kind of like returns on investment with the need to maintain a public health approach. So we absolutely recognize that we need to be focusing on it as a priority, making sure that we're safeguarding oral PrEP, which we know is under threat now, given the funding constraints. But we need to continue to pursue these science innovations, because as things settle down, we need to make sure that we're working across partners to offer communities the options and the choices that we know communities are asking for. I should say the same goes to long-acting injectable treatment. So there'll be further updates from WHO on this. But again, it's the same kind of like message really. It's working with communities to recognise that we have to keep the innovation work moving, but we have to still prioritise making sure optimal impact from existing technologies. So while we're very excited about some of the opportunities with long-acting injectables for treatment as well as for prevention, our key role at present is making sure that we don't have stockouts and service disruptions for oral PrEP and oral treatment, and making sure that we get back to 2024 levels. We'll also see some interesting updates around the potential use of dual therapy as well later this year for treatment. And thanks to everybody who's been involved in the various values and preferences inputs into our guideline development processes. I know many of you in this meeting have engaged with us, and we truly value that partnership. GNP Plus is in official relations with WHO, and we're highly reliant on Florence, Spo, and Cedric and others in keeping our work real. So again, just a summary. So long-acting injectable treatment, we're pursuing that. You'll hear more from us this year. Again, guidelines for CAB-LAS PrEP from 2022. We'll hear updates around lenacapavir in Rwanda. And again, initial guidance and direction of travel guidance for long-acting injectable treatment. So let me move on.
I just thought I'd share as well that we've got some interesting game changers and innovations on the way for STIs as well. Our department covers STIs and viral hepatitis. So we'll be looking at some recommendations coming out around the use of doxypep and PrEP. So I think many of you are aware of that. Doxycycline use as prophylaxis can really significantly reduce bacterial infections, STIs, so syphilis and chlamydia. And there's also good news around the use of the MCMB vaccine for gonorrhea. So that's something we're pursuing this year as well, alongside new diagnostic tests for chlamydia, gonorrhea, and syphilis, and skin disease. And also we're looking at some new drugs for gonorrhea that help address some of the concerns around drug resistance. Our approach to the ongoing crisis is really around mitigation, simplification, and integration. And as we do this, I think we do continue to leverage the PHC approach where we can, and we do this with a clear focus on stigma and discrimination. We know that this is one of the biggest challenges as we move from HIV-specific services to services that are provided through general healthcare and primary care services. We need to make sure that this is being offered and delivered in ways that are respectful to the communities that are important to our work. We will have today online a Q&A responding to community concerns about accessing treatment. We recognise that, unusually, some communities are facing more severe possibilities of service disruptions, drug shortages, or stockouts. And so, inspired by HIV iBase, we've developed a Q&A that will answer the questions you can see on the screen here, really around some of the questions we're doing from communities around concerns about how they might be active in responding to the possibility of not having a reliable treatment supply. I won't say too much about this. It's quite technical, but again, as we look at our midterm review of the strategies, we are prioritising 3 areas really for this year and going into next year. Ensuring delivery of essential services and commodities, and engaging communities, particularly around intelligence sharing. This is something that we shared with the member states this week around how we're proposing to prioritise various elements of our HIV responses. So the first area is stopping the backslide and the rebound that we're potentially facing. We really do need to focus on essential services, particularly harm reduction. We're seeing deaths from overdose because methadone and other substitute therapies are being denied people. And again, we have a rapid operational guidance note. You can look at this in the slides that will be shared afterwards. But again, it's around regular and rapid assessments and community engagement. Then, once we've focused on stopping the backslide, we need to re-establish where we were from last year. So we've added in a number of areas. So this is again around the tailored and people-centered differentiated services, links to multi-sectoral action, making sure that we're focusing on stigma and discrimination, adding in the work on data and information systems, and taking services and programs to scale. And then again, following on from that, adding further the work that we were really keen to do around building toward accelerating our work and building towards sustainability and sustainability planning. And then when you look at the whole range of actions that are in the global health sector strategies, we add all of those back in if we're keen to still strive for those 2030 goals. And again, we need to keep this as part of our work because it is part of our strategic framework, but we recognise that some countries, perhaps the non-donor reliant countries, will be in this position, high income and some higher middle income countries, but the vast majority of countries will not be able to prioritise to that extent. So again, some process updates. We will be convening stakeholder input this year to how we move with our course correction of our strategies, and we will be looking for
inputs from networks of people living with HIV. So inputs from this meeting will be really critical. They will help our thinking, as will some key survey responses and perhaps consultations we'll organise later in the year. So for my last slide, I'd really like to emphasise that while innovation will continue to be really important, we will not give up on this. We do need to recontextualise given the unique challenges we're facing. Long-acting options for treatment and prevention show great promise, and we need to balance that with making sure that we're optimising the uptake of oral options for all communities in need. Integration will require us to continue to double down on stigma and discrimination work, and we need to really prioritise getting back to where we were last year. Community engagement is key, and we need to really make sure that community-led monitoring is informing our work and our thinking, and encourage great solidarity between the various networks, people living with HIV networks, key population networks, women's networks. That's going to be critical. And then also, please do engage with the strategic opportunities this year, both with the new global AIDS strategy and our midterm review. And then finally, just a note on country ownership. These are big changes, but they're huge opportunities for us. And it's really important that we strengthen relationships with ministries of health. They've often worked at a disadvantage. Salaries of people working in ministries are lower than those in the organisations that have been well funded by the US and other partners. And we need to start to redress some of those balances if we're serious about moving forward with sustainability. So I think that sense of solidarity from our communities to ministries where we can is really important. I was so heartened to hear from Zambia and South Africa from government officials last week, where they spoke with real passion and thought and insight into issues around mental health, into issues around stigma. So I think we need to find the goodwill where we can with our partners who are in government as well as outside of government. And we need to really focus on simplification and impact wherever we can. So with that, thank you, Cedric and colleagues, and thanks to my colleagues in WHO who supported this work and this presentation. Thank you.
Thank you so much. Yes. Thank you so much, Andy, and sorry that you could not make it. I would have loved to be with you in the room, but thank you for at least trying to be online as well. It's helpful. Again, you have 2 minutes to write down the question for Andy as well, and then we move to the last presentation from Dr. Nduku, and then we go to the Q&A. And thank you for your patience and understanding.
Am I cutting this?
Yeah. Yeah. See. Huh?
Okay.
Oh, you.
For myself, I give it to Flo.
Okay.
Want to project it or
Yeah, they can. Whatever you prefer. Let me double check. So. Very good. We can do from here. All right.
Good morning. Okay, can I try this again? Good morning. Good morning. Thank you. I'm smiling. My name is Nduku Kilonzo, and I am currently the CEO of a consulting company, Yamaya Health Advisory, and I come from having worked in the private sector, civil society here in Kenya, as well as having been the CEO of Kenya's AIDS Control Council. And so I am bringing and coming into this from a whole different range of perspectives. I'm going to have in this conversation perspectives that are my perspectives, but I'm also going to utilize and leverage a little bit of data that comes from the way governments are thinking. At the moment, in my health advisory is working with about 40 governments, particularly national aids commissions or control councils, or, let me use the word commissions, from Africa, Asia, and Latin America on the question of sustainability. And so my conversation really is reflections about where we could go. I would invite that as I give my reflections, that they are, some of them, going to be a little bit challenging for us to think about, for us to accept, but we do need to really start to look at what we need to do moving forward. Because I think we need to start with the reality that funding of the past is past. So we have a lot of proposals and suggestions of what we want to do, of all the programs that we want to do. I will use an example given yesterday. If today I am no longer working, I lose my job, or my money has been reduced. Kitchen basics are you go back to the house and you start thinking, what is it that I give up, and what is it that I must maintain? What is the bare minimum quality that I must maintain, and how do I work my budget and everyone else in my household around that? Instead of going to work with 3 cars, maybe we could carpool and use 1 car. And really it's about that kind of realism that we have to think about. With that understanding, then the question is, what is the new future, or the future moving forward? So my reflections. Governments and country stakeholders have agency. And there are systems, mechanisms. They will need work, yes, but this is the gateway to sustainability. My second reflection is the response must be redesigned to work within mechanisms so that if tomorrow resources, someone else says, we have some resources for you to do this, and in 5 years they take away those resources, that where we are left is not the place where we are starting again and asking ourselves, how do we move forward? That is what we must do. And therefore it comes back to national system, it comes back to the systems that you have in country. PLHIV networks, because I'll speak about this, were there at the beginning. And they're required now more than ever. But the thing is, they are required now in the new form, understanding that we are not dealing with the challenges of lack of treatment. We are dealing with a different type of challenge. So how do networks reorganize in this context? Prevention, right now nobody's talking prevention. Let's just be really honest. So is that the conversation we are going to continue? Are we going to go back to pitting treatment against prevention? What do we need to do? How do we change the conversation so that then prevention becomes something that we can deliver, even when we may not have the kind of external resources that we had for all these prevention systems and projects and programs? And then finally, we do have other sectors in our countries that have capacity, infrastructure, and were really crowded out in the context of the resources that we had. And how do we harness this potential? So I'm going to also use some data that comes out of a position paper that was done by Director Generals of National AIDS Coordinating Authorities from Africa, Asia, and Latin America. And the position paper was informed by the recognition that the sustainability conversations we were having were not really looking at particularly the issues around systems, particularly the issues around the most vulnerable points to the donor funding that we had. And that is where we are today. So one of the questions that DGs ask themselves is, we've had very many iterations of sustainability. We started with country ownership, then we had conversations about investment cases. At some point we had SIDS, sustainability indices, sustainability index dashboards. At some point we also had investment cases and looking for innovative financing mechanisms, but somehow sustainability has been elusive. So why? And DGs felt that there were 5 key reasons. The first one was lack of a common vision. Whenever you went into a sustainability meeting in country, including last year, and you asked the person from civil society, the person from networks, you asked the person from the government, or you asked someone working for global health institutions, define sustainability, or what does sustainability look like to you when the response is sustainable? You would get 5 different responses. There wasn't a common shared vision. And so part of it was, I think, one of the biggest challenge around crafting our sustainability responses. The second one was the adoption of a one-size-fits approach. The challenges that are faced, and we were talking, I saw all the data that we saw, are faced in, let's say, MENA or in Eastern Europe, or in West Africa, West and Central Africa, are not the challenges in East and Southern Africa or in the Pacific. And so the question was, if we use the same model, the same tools, in the same way, are we actually going to be able to address those challenges? The other, we felt that somewhere along the way, HIV prevention was being left behind in the sustainability discussions. And finally, DGs felt that there wasn't a focus on transition management. If you are going to transition anything, we were saying we want to transition the HIV response from what it was to something else, which had various definitions, but the management of how to get there. There is no transition that has ever been successful without being clearly managed. We weren't putting in place management structures for sustainability, for transition towards that sustainable approach. But we also felt that this was the biggest challenge that was not being addressed. And this was the donor-driven model that was incompatible. And I say was because I feel like post-2025, it might be in the past, incompatible with government-managed services. Now, the vertical approach has been fundamental to getting us where we are. The progress that we have seen in the HIV response was partly driven by the fact that there was dedicated resources, there were dedicated systems, it was great. But if we were going to talk sustainability, we needed to ask ourselves the question, does this system align with sustainability? This is a drawing of, let me call it, Cedric Health Center, okay? So this is Cedric Health Center. If you went to Cedric Health Center, and all of us are from countries, you would find the pharmacy, lab, ANC, NCDs, outpatient management, non-communicable diseases, IPD, inpatient and wards are run through the Cedric Health Management team, right? Then you would have ART that was somehow linked with this and supported and provided through here, largely co-located, but was also linked to NGO Nduko that had its own human resource, that had a whole system around data that was reported through a mechanism that was funded nationally. And that mechanism, then you had the same for labs. PMTCT would have NGO, who is the next person I can see here, Israel, and then it would have HR, and then you would have a CBO that is linked to mother mentors, and all of these have their own infrastructure of data tools that are related to that institution, but also related to the national mechanisms, and not always aligned or interoperable with the National Health Management Information System. This is the reality that we have been living in, and we have had for a long time. So it was good to get us where we needed to go, but it was not going to get us to sustainability. So it was almost like what got us here will not get us there. And we were starting to talk about how do we get there. And so as we were having these conversations, we asked, so what would the vision from the DG's perspectives of a sustainable future look like? And there were a number of things that were put in place, with regard to service delivery, surveys and data, with regard to supply chains, prevention, human resources and technical capacities, PLHIV communities, as well as financing and leadership. So it was always about where we are and moving if we are going to attain sustainability. So 2025, Happy New Year happened, and then the directives, let me put it that way, and immediately after the directives, DGs met and said, look, met on 31st and said, in the last 10 days of the directives, everything that we said was the biggest vulnerability for sustainability has collapsed. What needs to happen? So I'm going to, and they had conversations and developed tools and looked at three things. They wanted to say, how are countries transitioning? What are the priorities for transitioning? What are the pain points for these transitions? And country assets and opportunities that can be applied. Now, as we talk about this, you will hear me mention, and I started by mentioning earlier, governments. And it is because governments have a responsibility to be able to ensure, yes, we've had support for a very long time, but the primary responsibility for treatment, for care, for ensuring that our citizens get the services they need are governments. So government facilities, one of the things were operational. They remained operational. What happened is there was immediate pivot of service delivery to government facilities. But that pivot also then came with influx of people, challenges to the system, because that pivot was also accompanied by loss of staff who were already working within the NGO-funded facilities. And this was only for treatment, because where did we first go? We must ensure that treatment is functioning. Standalone NGO services, these data are from not about 20 countries. And for the countries that are in orange, that have ongoing and functional community services and NGO standalone services, are the countries that are in LAC. There were 4 countries. In LAC, that is Latin America, and in Asia. For all the countries in West and Southern Africa, West and Central Africa, East and Southern Africa, NGO services are either partially or fully disrupted, and many of them fully disrupted. And community services as well that were supported through NGOs. This is not in reference to the community health infrastructure as is designed and run through ministries of health. Then we also had the question of data systems. And again, data systems have been largely partially. And what we realized is that some data systems are working, some are not working. Some facilities have EMRs that are functional. Some EMRs were no longer functional, so patient data was not available. We were moving patients with data that is not available because the system that is in the health facility is not working because the NGO stopped working yesterday. We had data for the supply chain maintenance and management. What do I mean? Commodity tracking, in-house commodity distribution became suddenly either inaccessible or unavailable. In some countries, the government went into a bilateral engagement with the US ambassador to try and get those systems open. Some of them have moved forward, it has happened, some are challenging, but we all know that systems and the data is problematic right now as we are talking. Then there is also questions, even if it is open, for how long, who owns the license to those systems? Where is the intellectual property and the payment for those systems? So they might be sitting in the facility. The data is in the facility, but the ownership of the system and the control of the system has not yet been, sort of finalized. And so what we also found is that the countries with an exchequer-funded health management information system had less severe disruption of either their data chain, their supply chain management information, or their patient data and facility data. Now, I'm not sure we have any country that really has prevention data that is consolidated and that is available. So what are commodity stocking levels? We do have, most countries, or not most, all countries do have ARVs and various stocks in terms of commodities. Obviously, condoms are where we have lists information. But I think the bigger question that we need to be asking ourselves, and this is the question for us here as persons living with HIV and networks, is where these stocks are the residual effect of the systems that were functioning, because these were in pipeline or in country. In the next 5, 6, 8, 10 months, are we planning now? Are we asking ourselves what's happening now to ensure that in that 9 months that commodities are available? We had several supply chain systems. The ones funded through PEPFAR, Global Fund, and governments. What is the plan to somehow transition that in a staged manner that does not result in stockouts across, so that in 9 months, 10 months, we have commodities and we don't go back to a situation of national versus donor-funded commodities, because we really cannot go back there. Human resource. We have seen significant attrition of human resource. In 12 countries, we reported about 130,000 healthcare workers, of whom almost 60% of that are frontline healthcare workers who suddenly stopped working. We've been talking a lot about human resource, but I don't think we often actually quantify what that looks like. Now, these workers are not working when we have an influx into the public health systems. And then we also find that even in countries that have resources to absorb them, and there are 2 countries that immediately their governments gave them resources to be able to absorb at least the frontline healthcare workers. There were challenges. Number 1 was the challenge of rationalization. All these NGO employed staff supported by donors were employed on different terms and conditions and through different mechanisms. So legally, they cannot be absorbed. Every country, whether it is a developed country or a developing country, has a public service, civil service authority through which somehow, healthcare workers and other people get paid. So there is a challenge. And then there is the fact that many other countries also don't have the resources. So those with resources have a different kind of problem. Those without resources then don't even have the resources to absorb this stuff. So how do we retain this capacity? Now, moving away from systems, and I've spent a bit of time talking about systems, because systems are so fundamental to whether we continue to have the services that are essential or not, both prevention and treatment. But I want to bring us back to why we are here, and this is the networks of people living with HIV. At the beginning, the political attention we got around HIV was from networks. Some of us here were at that beginning. Others have joined. Collaboration with national governments. But that collaboration was not without tension. It was places we collaborate, places we fight. Places we collaborate, places we fight. So the question becomes, is it possible now for us to sit back and say, where is it that we need to collaborate and where is it we must hold accountability? Because that's the conversation to have. Treatment access, PMTCT programs, mentor mother programs, getting people were all supported and have been organically grown from communities of persons living with HIV. What do we need to do in the context of existing systems for community health services? How can we engage, advocate, find ways so that those systems are tweaked to make sure that they work for community services? And then we had the multi-sectoral response with specific regard to national AIDS commissions. But over time, we have seen reductions in resources for networks of people, specifically networks of people living with HIV. But also the other thing that we have seen is that as we have had global civil society as a global sort of term, it became difficult to show the difference between NEFAC, the network of people living with HIV in Kenya, and FHI, because they were all called civil society. Isn't it? So where is the unique selling point that of communities organizing at community level, and then how they link to networks? So I think the road ahead really is about the voice of people living with HIV coming back to the table. But you have to define, it cannot come back in the same way as treatment activism. It will not work. It has to come back in a different way. What is that different way? And that's the question that I think over the next 2 days you need to be answering. Prioritization, I can see Cedric is looking at his watch, so I am going to finish now. And then around prioritizing PLHIV action. So if you're going to mobilize resources, who do you mobilize resources for what from? You're not going to mobilize resources for advocacy, perhaps, on an accountability from government, but you can mobilize resources to deliver community services from government. We also have to be strategic how we organize and how we sort of put ourselves and engage in our engagement. So I wanted to say, this is one slide, I'll not go through this. This is a bigger picture of what needs to be done in countries, in my view, based on a lot of conversations we've had. And there are two things here. Harness the private sector potential and harness the faith sector potential. We haven't spent time here. And perhaps I know that I have a team that is spending time on this to look at what that looks like and how it can be implemented. And for private sector, for those willing and ability to pay, for faith sector, we know that they, in many of the rural, most underserved areas, you have huge faith-based facilities, clinics that provide basic services. How do we leverage them? So I'll end with my reflections for networks of people living with HIV. And I think is to say that there are opportunities to start looking at advocacy, to start getting the data you need to start planning for the short term. These are short term. I haven't looked at long term. We had short term and long term yesterday. You have CCMs and NACs where you already sit on the table. How are you leveraging those to help with the issues around making sure that our supply chains are going to be functional? You have the networks and redefining what PLHIV leadership moving forward is going to look like. And areas of collaboration and areas of accountability, because those two are not mutually exclusive, but at the same time, they can be done within the same context of networks. HIV prevention. We have budgets in other sectors outside health. Should we only be looking at health sector budgets? community services received their biggest amount of exchequer services in social services. Are we looking at those budgets, or are we only looking at health budgets? We need to start to think back, multi-sectorality. And I've given an example of Uganda. I will urge you to go to the Global Prevention Coalition website. The DGs had developed some case studies, and Uganda has been able to engage and look at the different sectors, identify sector-specific risks, define indicators, and in 2022, I don't have the data for 2023, I don't have the data for 2024, they raised 16 million dollars was available for HIV services across those sectors. So the question is, how does it get harnessed? So there is opportunities in other sectors. We started the HIV response as a multi-sector response. We say multi-sector, but we only deal with the HIV, the health sector. I think we need to ask ourselves, what does multi-sector today mean? And then resource mobilization. There are many opportunities, there are some opportunities, and I think it's important to understand budgeting cycles. And I'll end with why that is important. We've talked a lot about social contracting. Unless we understand in every country how public finance management and the budget cycle of a country works, you'll never be able to access resources. Why? Because the way treasuries work and government financing works and how money that is collected as public money tax moves to private sector, whether that private sector is for profit or non-profit, is governed by public finance regulations and the cycle therein. I want to say, even for the US funds that we have received over the last so many years, the reason why they had data accompanying them was because there are requirements for reporting to their Office of Budget Management, which is their treasury, because they had to comply with the finance regulations of the US. And that will happen in every country. I think it is important. And the DGs did do a policy brief on implementing social contracting. You can share it, because at the end of the day, to access those resources, they will have to go through national, sort of structure, systems, processes, budgeting processes, and there has to be an accountable institution. And that accountable institution, in the case of many of our countries, you have the opportunities of the AIDS councils, and that's where we were coming from. I want to end by going back to the first place. Just let's remember, the funding of the past is past. How do we reorganize for the new future? Thank you very much.
Thank you so much, Dr. Nduku. This is really helpful. And let me have a look on one thing. Yes, I wanted to check one thing. This is the time for the conversation.
Let me just say there's a thank you note there.
Yeah.
Yeah, well, it's already there. Thank you. And I thank Mumbi, whom we work a lot with, and they have supported the work that is being done by the countries. I can't go without thanking everyone who's been involved. Asanteni.
Thank you. Yeah, that's ethically required. All right. The time for the conversation, I think maybe we put 2 chairs here, and then Andy and Jeff are still online, I believe. We can have them ready. So depending on the questions, we will listen to the questions, and if we have more than 3 questions for one individual, then we can have more for other people. But if the questions are for everyone, then we're going to limit to 3 questions in a row. We're going to have 3 questions first, and then so that we can narrow a conversation. Can someone help with 2 chairs so that Dr. Osu Mumbi can come here? I have the first question from, can you raise your hands like this so I can see you? Okay. So I will try to remember everyone, but also remind me. So The first question will come from Manoj. Well, I'm not supposed to forget. Manoj, and then we have Kenley, and then Mleleki, and then Pastor here, and then this is the first round. I see you here, and then let me see. Okay. Are you both? Can we?
We'll stand.
You good?
Yeah.
Like, cool. This is your another thesis for you. Manoj, and then depending on the questions, who is the question for? We can see if we do more questions for the
Sure.
round. Yeah.
Yeah. So thank you all presenters. My question is to Jeff, where he mentioned in one slide that 60% mortality among people living with HIV is on the people, those who are on ART. So do we have any further analysis like age group and cause of death for this 60% people, those who are dying even after on ART?
Jeff, can I confirm if you've noted the question?
Yeah, confirmed, noted.
Cool, thanks.
Thanks, and thanks for the presentations. Mine is also to Jeff. Jeff, treatment remains the key intervention for epidemic control. So what advice do you give countries in a constrained funding environment? What to do first, especially when you talked about other competing needs, prevention, and so on. I would just like to get your sense of what you're saying to countries. To Dr. Mumba, my fellow Zambian, in your third pillar, you talk about equity. And I just wanted to find out, when you say equity, equity of what? Equity of commodities, equity of services, and how do you realistically achieve that, given that, the commodities are usually driven, commodity pricing is driven by economic status, or services are determined by a country's ability to provide that, the level of services required. Just maybe a clearer elaboration of what you mean.
Can you pass the mic to Mulek, please?
No, thanks, Chair. My name is Mluli Gizazini from Napo, South Africa. Mine is just a few questions and comments. I think the first question goes to the first speaker regarding the decline on the usage of condoms. I think this is just a general assessment, because I didn't get it clear in terms of gender when you talk about the usage of condoms, that it has declined on which gender, so that we can be clear on how we respond as networks. I think it will also be good as a presenter to make some recommendations in this area. I think it will assist us. In South Africa, we have this tendency of men that they represent themselves for healthcare services very late. I'm so interested to know from other countries on how you respond to this, how you encourage men for a healthy seeking behavior, so that we can make sure that as we are implementing the close 1.1 million treatment gap in the country, then we're able to address that. Because I'm told that in terms of the data, the majority of men are the ones that we need to trace and link them back to for care. I agree. We need to change on how we do things, so that we can have a different approach. by focusing on multi-sector sectoral approach. Yes, it is really needed. As much as I agree, I think most of the speakers are saying communities must be in the center of response. And I concur with you by saying maybe we need also to make it sure that in every campaign or any interventions for HIV response must put human rights in the center as we are moving forward. We talk about the sustainability of programs and making sure that the resources are there. I think most of the issues we need to be very honest to ourselves. We are saying communities must be in the center, and that is what we have been advocating for. The reality is advocacy is very expensive, and not any donor, the way I look, that is willing to support it. And our nature as networks is more of advocacy. I so wish as we talk about these issues, we also address on how we invest in advocacy, because everything needs resources for us as networks to continue. Okay, I will. Okay, maybe let me conclude by saying thank you to GNP Plus and other global partners for making sure that for the PLHIV stigma index, there are non-negotiables. I so wish we can also include these non-negotiables in direct interventions of the findings. Because in our countries, we do research, we come up with findings, but in terms of responding to those findings, it's other people, it's not us as people living with HIV. Thanks.
Thanks, Murek, and sorry for the pressure. So yeah, because we need to manage time as well. Noting the questions, but also just to confirm if Jeff and Andy are noting the questions online. And for those who are going to ask questions now, please take a maximum of 1 minute to ask your question, but also please remember to introduce yourself. I have Pastor Jedo.
Gideon Baguma Biamujisha, the co-founder of the International Network of Religious Leaders Living with HIV, and now their current patron after the passing on of Archbishop Desmond Tutu. My question is to Jeff. It's actually clarification. Did I get him well when he said we should begin thinking of phasing out the language on ending AIDS? Did I get him well? Because for us, some of us know we can end AIDS. If you equals you means no transmission, and that means no progression to AIDS, then why should we fear talking about the end of AIDS? Maybe did he mean end of HIV, which are not the same.
Thank you. And then we have Dorothy.
One minute. And then the thank you very much, and thank you, the presenter. My name is Dorothy Onyango. I work for Women Fighting AIDS in Kenya. I'm also a founder member of ICW Global and also the Pan-African Positive Women's Coalition. My question goes to Andy, WHO. We are talking about effective treatment for people living with HIV. And Africa has the majority of people living with HIV. And every time there is new regiment, I think we are the last to get as Africa. Currently, we thought DTG was the best because that was what we had. And now we have TAF, which is not even available for us. They say we wait until you are very sick. I am currently aging with HIV. So when am I going to wait for that when I'm very sick? Does it work when you are very sick? Will it work? Isn't it more expensive to have that happen? So probably you need to, Andy, you need to help us pressure our governments to ensure that those medications are available for people who need them, not when we are sick. Thank you.
Thank you. Yes, Kamal. Please introduce yourself and then ask the question.
James Kamau from Kenya Treatment Access Movement and a founder member of GNP Plus. Tumombi, you've talked about the Abuja Declaration, the Lusaka, there's the 5% of GDP, there's debt to health. Excuse me, I think it's time we did a radical issue. If we take stock of that, it has not worked. What makes us think it's going to work now? I think that's what we are saying. Let's do things differently. We can't just continue saying the same thing at the same time. Dr. Nduko, thank you very much for your presentation, and I agree with you. For example, we have a hospital here in Coptic providing ARV services to over 3,000 patients. When the stop order came, the faith-based organization board sat together and decided they are going to pay the healthcare workers and the people who are providing for the services to continue because the drugs were there. So I think this is something to do. And it's the same thing that happened to Bagathi, which was led by Dr. Gethenji. In fact, he should have been in this meeting, where he got the board to get funding to pay for them. So as it were, with this crisis, it is giving us an opportunity to come up with solutions for moving forward. And like you said, does it mean changing the issues so that we pay less? Thank you.
Good morning, everyone. I am Chomkama Flavia from the National Forum of People Living with HIV Networks in Uganda. And particularly my discussion goes to Nduku, and I want to applaud what you have shared about the PLHIV networks. And for me, in light of integration, I think we need to define what community-led integration within the current health sector strategic planning and global health sector strategy is concerned, because we need to be very clear what is community-led. What we see mainly is community-based and doesn't serve us as people living with HIV. So we need to have a minimum package for community-led integration, and particularly for essential services. The second one is around, right now we are having confusion. We have a lot of stories coming from the committee about stockouts, about violations. How can we quickly come in and document these stories to inform the discussions that are going on? Governments are saying things are okay. The integration, for instance, in Uganda, the integration of standalone clinics into the public health facilities is going well, but we know it's not. We need to quickly come out with emergency interventions for those communities that are most at risk, the adolescents and young people, the KPs, who cannot, who have a face to lose, who can't go to the outpatients department. The next thing you talked about was about participation and representation in key decision-making committees, even including the budget processes. We need to quickly claim this space, because that's where the money is doing the rounds, that's where they are discussing monies. And so we need to find a framework for ensuring that we start from the ground as we set priorities, because countries like Uganda start in July. How do we ensure that we part and parcel of identifying the questions. And finally, I think what we need to do now is to repackage positive health, dignity, and prevention, or rather what we used to call positive living. Because right now we are at crossroads. People are dropping off. They're having holidays. The long lines at the clinics are not. If we need to stabilize the situation, we must start talking about positive living, positive. What we did then before ARVs came, because right now we are not sure we have ARVs. I personally, in my position, don't have at my center Abacavir and Lamivudine. How about those in the communities? What is going on? How do we ensure that people continue to adhere to the little they have and try to continuously follow up? And then finally, for our organizations and as implementing partners, social contracting is the way to go. We need to come up with a guidance, global, national, that ensures that our organizations are singled out as community-led, and they are not put in the same category as FHI 360 or whatever, to ensure that we receive resources from the Global Fund, from the global programs that are bringing in resources, GFF, and also the government itself, to facilitate us to do the work and ensure that the expert patients, mental mothers who have been laid off, are back in the system. I thank you.
That's mine. All right, thank you. It's fine. Let me double check something, but in the meantime, I want to make a very small announcement. I noted all the questions. Give me a second. Jeff, how many questions do you have until now?
I have 3 addressed to me.
Okay, Andy?
I have 1.5, and I'd like to answer another half.
Good. Okay. Is there anyone who has a question for Andy or, okay, and Dr. Nduku and, okay, Maxi, you are not on the list, but I will come to you. So I go to, give me a second, I'll check my list. To Vu and Elizabeth. Jane, I will come to you next. But also in the meantime, everyone, so there's a tea. And I'm going just a small announcement. There's a tea there, but it's not really mandatory for you to go take it. It's just there in case you need it. We don't need to take a break now. You can just walk a little bit and then take your tea and come back here, and then we continue the conversation. So we're going to do that so that we gain time. Vu, and then Elizabeth.
No, firstly, I want to thank all the presenters. I'm going to focus, I'm Vuisega Dubula. I'm going to focus my questions to you, Nduku, and I really am fascinated by your presentation. One, it's taking stock of what's happening now and what we need to think differently. And you are smiling because you know I'm going to ask you the hardest questions. First, we are, maybe this is a deep-seated issue in the sector. The trust between communities and government is one of the reasons why we have a disjoint effort in Africa. What are we going to do with the DGs you've mentioned to build that bridge? Because we can't be expecting communities who are now living in a shrinking civic space, who are going into hiding, who are highly criminalized, to sit in the same room with the very governments who are criminalizing them. And that's not only happening in Africa. I'm just saying that's the context within which we must come on the table. It's not us who must come to the table, it's all of us coming to the table in equal footing, both government and civil society and networks. If we can work on our relationship as an enabler for us to think of this vision and co-create this vision together, we are in it. We are 100% on board. But if we're expected to come on the table as patients who know nothing, who are not experts, who have not been building the movement and building the HIV program in Africa for 30 years, who have expertise, we have doctors, we have nurses, we have, I can mention all professionals in the sector. So we are not coming as the patients of 2000. We are coming as doctors. So we are coming to support and advance Africa's vision to get where you want to be. but acknowledge that we have that capacity in the networks. And we are bringing that capacity, not expecting money, but expecting to be heard. Count on us. We are putting our name down. Count on us. When you count on us, you have to democratize health governance in Africa and allow people not to be pushing doors and cracking walls to get in. We also have to think about our contribution in the systems, that we want a people-centered, human rights-focused, community-led integration. We want integration. That's the only way. And we got ourselves in the disjointed integration because there wasn't enough room for us to change and shift PAC in what it wanted to be. Now we want to be on board to revision with you in a PAC that serves everybody, including those who are deemed in other countries undesirable. We are here to help governments to get there. The last thing I want to share is that in that building of trust, we are not only asking for money, we are asking for what we contribute, for our labor to be remunerated accordingly. That labor, I'm talking about community health workers. I'm not talking about Vuiseka. Vuiseka must go find a job somewhere else. It doesn't have to be in the sector in order for me to sit in the room. I'm asking for community, for community health workers to be remunerated if that is the capacity needed. So let us not be seen as the rejected people of the PEPFARs and the UNAIDS and the USAIDs and the global funds who are now coming begging with empty plates in front of governments. No, we are here because we care. And these are our communities. We will die on this land. And we want our governments to recognize that we are not just coming to beg for money, but to beg to be part of the solution, including where we need to be paid to be paid.
You have to translate to me what you said to me. All right. We have Elizabeth and Emmanuel, and then are we close for now? Because I think I was equally dividing the question to all panelists, and then we got to the second round, and I think I'm managing well right now.
Can I ask both my questions?
Yeah.
Can I ask both my questions?
Yes, you can.
Thank you so much, and thank you to our presenters for the beautiful presentations. My name is Elizabeth Atieno Onyango. I am from Mombasa, Kenya, and I work with the Coast Sex Workers Alliance. My first question will be to Jeff, and this is about children. When children are excluded from vision-setting conversations, we risk reinforcing the same gaps we are trying to close. So my question to you, Jeff, will be, how does the current strategic vision account for the unique epidemiological trends amongst children and adolescents? Are there any plans to strengthen pediatric data and response mechanisms? And my second question is for Andy. Thank you so much for the presentation about the many existing prevention technologies, including the STIs game changers that we saw in your presentation. However, I would like for us to take note on the fact that women, especially women from the global south, we bear the prevention burden. And I remember there was a time when we were very vocal about the one female-centered prevention technology, and that was the dapivirine vaginal ring. And now the conversations have really died out about that one particular prevention that is female-centered and that we all want. It was missing, and I would just like to know what it is that we have in plan in considering that in conversations about a prevention method that is specifically for women. Thank you.
Thanks, Elizabeth. Thank you. Emmanuel, remember to introduce yourself.
All right. Thank you. I'm Emmanuel Barare. I'm a member of the HIV and Reproductive Health Work Group at WCC, Council of Churches, and a member of Y+ Kenya. Now, my first question goes to Dr. Kilonzo in terms of the statement you made in terms of, are we making or do we need to relook at prevention as a way of making this sustainable future a reality? But my question will now go to all the presenters in general, and maybe even all of us here in the room, is that what we want to achieve through this gathering today and tomorrow is try to understand how we can be able to get and secure a sustainable future for this response. But yesterday, my key takeaways were we cannot know where we're going without knowing where we've come from. And speaking here as a young person living with HIV, we really do want to appreciate all the efforts that have been made before us to pave the ways and to really open the doors in terms of treatment that we're able to see and enjoy today. But we really need to agree that as Sub-Saharan Africa, the young people are the majority of the population at the moment, around 70%, and this is only set to go higher. So my question will be, with our plan for this sustainable future, where our interventions in terms of having the young people within every particular intervention that we want to achieve? Because without us being in the room, without us being in these conversations, we are the future. We thank you for everything that we've been able to see and be able to do for us. But we need to pass that baton as well and be able to give young people the chance to lead this particular response to get that future that we want. Thank you.
Thank you. So this is the first round, and I've noted all the... Yeah, I will come back. So this is my unilateral decision. For people online, I will give you 5 minutes for the questions, and people in room, you got 4, because I will say the reasoning is you are here, and then you can also have a conversation during lunch with the colleagues here, but people online, they don't. So we start with Jeff, and I will really be strict with time, and then Andy, then as we did with the presentation. All right, Jeff?
Thanks so much for the wonderful questions and discussion. So the first question I had was about the age group and causes of death for the people on ART who are dying from age-related causes. That's estimated 60%. And so there are estimates for that, for those ages, for the age and sex of those people, and also there's some information about cause of death that doesn't come out of the spectrum estimates that we're from, but there's some other data about causes of death. And I think the other thing that's important is there's some information about the extent to which those are people who initiated treatment late or initiated treatment with advanced HIV disease versus ineffective treatment versus treatment failure. And so I think all that sort of information is available. If you'd like to follow up, I can connect you with some resources around that. I think it's really important as highlighted. The second was what advice, hearing the message about effective treatment being the cornerstone of sustaining our progress, what advice do we give countries in a resource-constrained environment? And I do think that message, that everything is built on the foundation of continuing to deliver effective treatment is really important, and that we have a clear and consistent voice around that, because I think that, in our space, we hear the multiplicity of things that are important and the nuances and the balance of considerations. I think sometimes the people outside of our space who make important decisions that impact the priorities that happen in HIV. You hear about lead, you hear about various things, and sometimes that kind of how that all fits together is not so clear. And so I do think it's important that we really focus on making sure that everyone understands that treatment is non-negotiable, and also the importance of having systems in place that ensure that. So the systems gaps that Nduku talked about, and I think maybe as a whole community, we haven't given sufficient attention through supply chain, through management, through the sorts of things that just make it possible to have ARVs in clinics without interruption, and that's something that we need to be louder about, because other people, frankly, USAID has managed that for a long time, and so we haven't had to pay attention to it. And I think we need to recognize the importance of that, be very vocal about those systems components right now. There was a question about the decline in the use of condoms and amongst whom condom usage is declining. There was a question about unclear by gender, and I think one of the things to note in epidemics that are predominantly heterosexual in terms of the nature of transmission, it takes two, and so there's an element of any declines are amongst both genders, but of course there's important dynamics and decision dynamics within that, and I think it's not at all clear, certainly from the modeling data, you can't tell us how you would go about addressing that, but I think that many people there around the table and elsewhere will have much more insight into what the specific barriers and dynamics are that need to be addressed around making the case for why continued HIV prevention and condoms continue to be important as part of our HIV prevention portfolio. And this is something I know Duco also has lots of excellent thinking about and pushes me on all the time. And then regarding the question about phasing out the language around the end of AIDS, my opinion about that, and I just want to express that was my opinion, not kind of pronouncement from anyone else. But I think that the challenge there is of course, as stated, that's 100% correct, that we can talk about and should be talking about trying to end AIDS and not have people with affected by clinical AIDS. But I think that that's language and nuance that makes sense to all of us again. But I think sometimes that nuance is lost when we talk to U.S. Congress people, when we talk to heads of state, when we talk to private sector leaders. The distinction between ending AIDS but sustaining HIV programs is a subtlety that I think just gets lost. And I think that perhaps quite right, the people heard the end of AIDS and thought, that means the end of this being a political priority for me, that means the end of me needing to put money into this, etc. And I think that's possibly the nuance that's clear to us, but not widely clear. So I think we need to be talking about the 35 million people who are going to be productively living with HIV in 2050, and what it takes to get there as a much more active conversation. That's my kind of reflection from many discussions on the topic. And then lastly about children. So children are very much a part of all of the global strategies and frameworks. WHO has some really excellent and really thoughtful strategies about the steps to take to end AIDS in children, and that's framed around firstly continuing to drive down new infections amongst children by closing gaps in vertical transmission. Be very focused on, I think also has a very high priority right now, continuing antenatal HIV testing and treatment initiation. That's a very relatively low cost and high impact that we need to be focused on sustaining. And then in terms of reaching children, first you recognize that it's true, and it's a good thing that the number of children with HIV is declining pretty rapidly now in most settings, because we've been relatively effective at turning off the tap and children aging into adolescence and adulthood on treatment, but also continuing to find reach children with testing. And the rates of testing, so HIV prevalence in many of our hybrid countries between older children, adolescents, and young women 15 to 19 are actually pretty similar now, but we test young women many more times than we do children. So I think that's part of the mechanism of children. So if that's a priority, we have to diagnose them and keep reaching them. And you have to test people if you want to diagnose them and reach them with services.
Thanks so much, Jeff. Andy?
Thanks, Cedric. Picking up on a few points, bringing the Jeff, I think language is really important, and I think perhaps we need to make sure that we're not pitching treatment against prevention. So let's talk about antiretroviral therapy and the centrality of antiretroviral therapy in a lot of the work we need. So that speaks to treatment and to prevention. So that's the first point. Second point is really around Dorothy's question around treatment options. I couldn't agree more. We've really been trying to focus in on this options issue for lots of reasons. Equity being the one. Global equities is the most important one, of course. We know the reasons why we are where we are. It's about volume purchasing and getting, as many people onto effective treatment as possible. And the conversation was in a very different place last year. And I do think that we need to continue that conversation around options. And we need to do that through different ways and continue to have that combination of global level pressure around generic availability and also coming up from community level and conversations with governments. But we also have to recognise that it's great that Boo is in the room there, that Global Fund will be increasingly taking on the burden, if you will, of making various options available at scale to communities and to countries. And we need to continue to do this. We need to continue to have it on the agenda. But volume purchasing and keeping people alive has to remain our absolute priority. And so we need to continue to do the two things at the same time. Again, all of the usual players are involved in these conversations. MPP, WHO, Global Fund, others, and UNITAID. And I think that we need to continue to push for options and making sure there is equity and availability. You'll see a shift in some of the WHO guidelines, I think. So we will move towards a little bit less rigid focusing on first-line regimens, and this is really where we need to go. Again, recognizing that some of the mechanisms that we were speaking to with those guidelines were around PEPFAR and its models and its purchasing power. So we are entering into a different world, and I think we do need to also leave more space for country-level decision-making around what is made available. But we still have to keep that balance right between volume and impact and options. And I think there are some, I think you pointed out, Dorothy, that we need to be thinking about this from an advanced HIV disease perspective, from an aging perspective, and from continuing to look at the various options. Options also came into the other question that came to me around women-centered prevention options. I didn't point out the vaginal ring because I was talking about new innovations that would be subject to new guidance from WHO this year. Vaginal ring continues to be an important part of the package of options for women, and we will continue to promote that. I think one of the things we found through our work with communities is that there is interest from women in injectable options, almost as a better alternative to vaginal ring, but that does not mean to say we will be moving in any way to remove those options. We've had a Women Living with HIV advisory group for some years now. We've not convened that group for a year. We should try and do that again this year if we can. But that group has been consistent in its advice to us around options and women-centered prevention options as well. A couple of things around some of the other points that were raised during discussion. I failed to acknowledge the role of artificial intelligence in my presentation when we were thinking about innovation. I think we do need to be thinking about this. We need to also be thinking about the role of young people and how we can support young people, particularly positive communities of young people, to be really leading the work that's required around the new capacities, the new knowledge, the new ways of working.
Are you managing the Zoom?
And that interface between young people living with HIV.
Is it possible for not now, for the last round, to display time? Do you have a time? You don't have it?
So I think we need to bring that into our thinking as well.
Okay, no problems. Yeah, I will just...
And then just to say, oh yeah, there was one point, I will finish on this point. There was a question about encouraging male housekeeping.
Just
I
to
think
say
for
that
HIV, one of the reasons why we combine our work with STIs and hepatitis is that there are opportunities to really be thinking about talking to men about sexual health, sexual performance and sexual longevity.
and rather than focusing on HIV, which can really push them away from services. And when we do that, so we're asking people to come in for checkups to make sure that they are able to perform sexually and in their relationships in an optimal level. This was one of the things that we drove a lot of demand for GNP, for example. I think there are opportunities for us to do much more around male toxicity. So I'm going to pause there, Cedric. I'm going to have to drop off this call now for half an hour later. Thank you so much.
Thank you so much, Andy. This is very helpful. Thank you so much. Now we come back in the room. Mombi?
Thank you. I think the first question was around equity. So equity of what and how do we realistically achieve that? I think from my perspective, I look at equity in terms of, I look at equity as fairness and impartiality, particularly in reference to access to treatment and care. We have a lot of people who, I think from some of my slides, we did see about 23% of people who do not have access. We saw a lot of disparities across countries and regions, even at population level, at country level, at subnational level. We have a lot of disparities in terms of access. Some have an abundance of, like urban areas, for example, you have easy access to treatment. People in rural areas have, do not have that luxury, I would say. So we need to have some element of equity in terms of access to treatment and care services, as well as the quality of those care treatment and services. In terms of how we realistically achieve that, I would probably throw it back to the room based on, and I do that because we are the experts, so to speak. Like Vusi said, we've been living with HIV, and we have 30 plus years of experience, and we know who our community members are and so on. So how do we ensure that even as we go forward with the push for integration and government ownership or leadership and so on, how then do we ensure that our people, our community members, our brothers and sisters have better, similar access to treatment and care that everyone else enjoys? And then I think the last was Emmanuel's comment on youth involvement and engagement. This is a question I've asked in other meetings. I think in the UNAIDS sustainability discussion in Johannesburg sometime late last year, I did ask the same question. We are sitting in a room as technocrats and experts making decisions. Even in the prevention meeting, we had this conversation 2 months ago with Florence. We are here making decisions and discussing the future of the response when the people who are the bulk of the population that we are making the decision for are not in the room. I remember in that meeting, I'd asked by show of hands how many people were below the age of 30, and there was not a single hand. So it's good to see that in this room we have quite a huge number of youth, and it's important that we involve them, engage them, because their view of HIV and what it would take to reach them, what has worked so far in terms of reaching the youth and so on. They are more in the digital age now compared to some of us who can't even work through social media posts and so on. So we need to make sure that we bring them on board, because the dynamics of engaging the youth are very different from what we grew up with and what we know. Thank you.
So can I just start on the youth question? And I'll ask, for all of us who are in this room who've been around for a while, how many of us can say, I have a young person I am mentoring now around me? If you don't have a young person you're mentoring, this is all just talk. Meaning that in my office, I have a young person who goes with me, who engages with me, who sees how things are done, who is part of the conversation. So I just wanted to say that it has to start with us. Now, Yes.
Leadership roles.
Yes.
Young people need leadership roles, not just, help us. No.
Yes, agreed. And the idea of mentor is so that then you can give them more and more. That's where I'm coming from with the mentor. So now, I had a couple of questions, so I'll start with the tough one, and this is about trust. Governments don't trust communities. Communities don't trust governments. This is mutual. Now, when you have a mutual breakdown in a relationship, there has to be recognition that it is mutual, and there has to be recognition that both of us need to start talking to each other. And appreciate that we both have faults, but we also both have strengths. So we cannot come at this as communities from government don't know what they are doing, blah, blah, blah. Governments cannot come at it. Communities don't know what they are doing. They are, it will go nowhere. I have taken your recommendation, Vu, around is it possible to create a conversation? I will take it back to the steering group of the Director Generals, and I'll say in your countries they are asking, can we even start with an online conversation? And I will talk to Flo, Cedric, somebody. So allow me to say we have to start with action somewhere, because if we don't, we will have this for a very, very long time. Number two is the question around community health workers. It has come up twice or three times. I want to say that governments have set up a community health infrastructure. We may not agree with how it runs and how it is set up, but it is the infrastructure through which resources are happening and healthcare workers can be paid. Because you will not be able to establish, we are talking reality, isn't it? A parallel system and expect that it will be paid for by the government when there's an existing system. So therefore my question on the table is this: how do we enter and engage and start ensuring that one, that system has HIV embedded in it? That number two, we start then having conversations about even quotas or people living with HIV delivering certain services, i.e. we must change that system to work for us and for us to start leading the conversations in the community. That is really my view. I might be wrong, but I am not sure I see another way in terms of community-led integration, health integration within community health services. The number three is the question around the challenges that we are experiencing right now. I'm going to say something that might be controversial, but I think we need to reflect on it. We are where we are right now in terms of all these challenges because there wasn't investment and focus and ensuring we were pushing that investments were going to strengthen the systems that are national service systems. Granted, there may have been tensions and challenges with government, but neither was there that push to go in that direction. So now we have very weak systems that we are supposed to be serving us. They cannot and may not be able to deliver in the same way that the systems that have served us have. We have healthcare workers who are no longer working. Some have been recalled, but we all know the continuing resolution is until September. So I think if we are being real, it is to say that how do we manage transition right now? How do we optimize our networks to ensure that the people living with HIV are able to get the best level of treatment? Yesterday we had a presentation about, engaging at the community, in our facilities and working with the facility level health teams or management teams at that level. It is very basic, but I think we have to start somewhere. Now, does that mean that there is no responsibility? And that's why I kept talking that government. And therefore, right now is, as we talk over the next 2 days, is to ask ourselves where and how do we mobilize the existing resources, Global Fund resources, how do we mobilize them to serve us, to strengthen the systems that will serve us into the future? And say, Global Fund should no longer have this system or this parallel system, we want it in this system. That until we in this room do that, we will be in the same challenge. The second gives me the segue into something Mululeki said, and it was very basic about, at the end of the day, these things need ching-ching, isn't it? That's what he said. He said, basically, everything here needs resources. So I will go back and say, the resources of the past are past in the amounts and the way they were delivered. So how do we, in these conversations, ask questions about how the available resources, because there will be some available resources, there are some, how do we harness them? What are the priorities that we are going to ask they be invested in to work for us for the time being? Because we cannot do advocacy the way we did it. It will not be funded in the same way, at the same levels, realistically. So what do we need to do differently? So for me, that is the conversations that needs to happen today and tomorrow. How do we go back and say, these are the priorities we need, and we are asking partners who are on the table to fund these 3 priorities across these countries or in this way. Some of them will say, sorry, no, we can't. Yes, we can. We want to. But this is the point of thinking, because that's where we are. Thank you.
Thank you so much. Yeah, there's one question that was not responded by.
Yes, my sincere apologies. I think it was James who had asked a question around the radical shift from the declarations, the Abuja declaration and so on, which haven't worked so far. Like probably less than 5% have actually met those targets for health financing and so on. I look at this in 2 ways. First of all, I think there was there wasn't any push to meet those because we had someone else paying our health tab. So governments, I think, got complacent, in committing resources towards those declarations because they were comfortable with, the global north picking up the tab for the bulk of our HIV and probably broader health services. In the absence of that, it's either we push and hold our governments accountable to meet those declarations that they committed to since 2001, or we then rethink and because like we were saying, what has brought us this far will not get us to where we want to be. So what then, or how can we rethink those frameworks and so on to help us get to where we want to go as far as how much money we need to finance our health and particularly HIV and so on and so forth. So I look at it in those 2 ways. Thank you.
Thank you so much. So this is the first round. I have a couple of other questions. I would just confirm if they're still valid according to the person who wanted to ask. But before that, I have an announcement to make. Any member of the press is required to slowly with their devices go see the gentleman outside there. You can slowly step outside a little bit. We are not excluding in the conversation. I think you are needed outside as well. So Maxi, your question is still valid. So is Jane. Just confirming. You still want to ask the question? All right. And Shalik? All right. So I will go with Maxi. Is there anyone who has a question at the moment? Okay. Dio. Yes, Tariq, I have you on the list. Sorry. Dio. We are closing the question, the last round. Okay, this is a success. Thank you, Max. Go ahead.
Thank you so much for the presentation. My name is Maximina Jokonya, Executive Director for Global Network of Young People Living with HIV. For myself, I just wanted to find out from Dr. Nduku, you are my inspiration, I tell you. But I wanted to find out in terms of the community data and evidence. Because right now we are struggling and we are seeing that the data has disappeared. But we know that community has data. and that is valid. And that is something that is lived experiences, and we've been collecting this for quite a long time. Whether we want to term it community-led monitoring or whatever mechanisms and approaches that we have, what are we going to do? Whether to institutionalize it or whatever term that can then be accepted by the standards of this data being viable, and for the likes of Jeff and our other colleague to be able to utilize that data. That's my first question. The second question is, we are talking about HIV and we have people living with HIV in the room. But we also know that the funding cuts that are coming, they're also affecting TB and malaria. Where is that conversation? Are we only saying that we are going to start the HIV conversation only, then we move to TB, or are there other people that are already talking about TB and malaria somewhere that doesn't concern us, but these two diseases actually affect us as people living with HIV? The very same systems that we are talking about right now, these very same communities that we are talking about right now, are the very same people that we also need to think about when it comes to TB and malaria. Just a quick question on that. If you have any thoughts on that, thank you so much.
I think I have Jane.
Thank you so much for the presentations. My name is Jane Nganga. Question to Dr. Nduku. Yeah. So have you considered incorporating data on the contribution of the faith sector, particularly the faith-based health system? Because this data would be quite valuable in informing the kind of collaboration we want to seek with the networks of people living with HIV, and especially at the regional level. Considering, for example, the Ecumenical Pharmaceutical Network brings together that over 32 Christian health associations within the African region, and each of these Christian association has maybe some over 1,000 hospitals. They also coordinate over 21 drug supply organizations, the likes of MEDS within the region. We also have the Africa Christian Health platform that also supports in coordinating and supporting the health service delivery within the various hospitals in the region, so that even as we talk and as we seek the collaboration, we already have data that can inform that, and creating, the necessary linkages that needs to be done and leveraging on that platform, because I appreciate the fact that you also appreciated the input and the strength of the faith sector. Thank you.
Thank you, Jane. Shirley?
Hi, everyone. Hello. Yes, it's good to see radiant faces. People are happy. I'm unique because I'm that healthcare worker you're talking about who's supposed to go home. I'm that healthcare worker standing between the organizers sitting here and the very angry patients out there. I'm the one who knows how many patients are dying in my facility, how many are dying out of advanced HIV, how many are getting kidney failures. I know who to call. I know at the community who I need. But my question goes to Kilonzo and the governments in general outside here, because there are a lot. When you're talking about first response, what are you talking about? Do you ask us? Do you engage us? Because if you decide a very capacity-built healthcare worker should go home, when the one you have available is not able to handle that patient, what are you doing? Are you solving a crisis? Are you giving birth to another crisis? What are we doing? I'm not saying the government is not doing anything, but what are we doing? Right now we are talking about getting funds. We should think about data. What data are we talking about? For example, if you ask me, I'll tell you in my facility, from January to, we are in April, from January to March, 50% of the deaths in my facility are from hypertension diabetes, people living with HIV who are virally suppressed. What I'm trying to say is we have achieved the third 90, but we are losing our patients to non-communicable diseases. We have cases of suicide. We have mental health issues. So how is the available healthcare worker ready to handle this patient when the first mistake we did is make sure HIV was a standalone? Because when I go to present, I can speak a lot. But when my colleague comes, she or he is not capacity built to do the same thing I'm doing right now. So I'm not saying I'm grieved. I'm saying I'm talking about the other healthcare workers who are out there, and our fate is not known. Second, we mentor, yes. We are mentoring our colleagues on the same issues. But how much? The systems we are talking about, in Kenya we have something called EMR, and it's a system that is working well. But how ready is the government ready to sustain this system? Because from January, I can tell you from experience, we're having a lot of problems. EMR is not working, data. And the government was like, the partner was supporting, sasa, 1, 2, 3, 1, 2, 3. The young people, hoye, mko wapi? They are complaining because they come to the facility, they have to stay over 1, 2, 3 hours. EMR is not working. So where is our father? Our mother is the government. Where are you? Because when you make decisions and say you want to see where to put resources, where are you targeting? Because you should come to us and ask us. When Dreams went away, Dreams is a partner that was supporting safe spaces in Kenya. Right now, the safe spaces are not there. That is the ugly bit I know. And I know what's happening to these young people outside there. So the government should come and ask me, Shalik, not Shalik per se, but the healthcare worker, now that we don't have this fund, what are you doing to bridge this gap? No one has done that. So when we say we are allocating resources, where are these resources going? When we are saying we're talking about K-pops, what are you saying about K-pops? Like, what is the problem with the K-pop? Yes, I'm a female sex worker, but what is the problem? What do you want to solve? At the community down there, there's a problem between facility and community linkage. Have we bridged that gap before we start saying we want to go and approach a community health provider to go and do this work, but you've not capacity built or linked that provider with the facility? So when you say we are allocating resources, we are working on first response, we are doing something called transition, what are you doing exactly? Thank you.
Thank you. And I agree, you are unique. And I also got biased, and then I gave you more minutes. But I was like, now we have to, sorry. But thank you so much. We have Tariq.
Thank you, Cedric. Thank you, everybody. So I think we had sufficient technical, biomedical data. Tariq Alawi from Morocco, from MENA Community Network of people living with HIV in Middle East, North Africa. And while I was watching the presentations, it highlighted the vision reserve that I have. When I say the vision, it's the politic that they are adopting to divide us. I'm not against division when it comes to have concrete data about those region or that region. We are totally agree, we need that. But when this division become to international decisions and international funding, here comes the problem. What we are facing today is the PEPFAR cut from many countries and fleets. We had this years ago in the MENA region, and I think nobody did stand with us. Why? I fully understand, because everybody was afraid that he lost the PEPFAR support. And what we leave yesterday, everybody is living today. So the idea is we have to change our vision. I'm not speaking about national networks because you are fighting underground, you are in the outreach front line, but I'm speaking about regional and global networks. When we come, once we are in high-level meeting with international stakeholders, our voice must be unique. Since the Denver Declaration, Abuja Declaration, Doha Declaration, all declarations, this says every people living with HIV in the world have to live access to treatments with dignity and everything. They don't say that people living with HIV living in countries or regions with high prevalence. Today, we are seeing that MENA, for 5 years successive, it's increasing cases. Why? Because it was left behind, geopolitical reasons or anything you want. But this 5 years, now we see the results. It's gonna be, and like the region, MENA region, there will be other region where today maybe it's decreasing, but tomorrow it will increase. We need to be one voice. Now, Algeria is again excluded from the voluntary alliances of lenacapavir. Who is caring? Mali, once there was the punch against the system, France, 48 hours, they cut all financement, including the one of HIV. How did it stand with them? Today, Brazil, Guatemala, Malaysia are also excluded from the lenacapavir voluntary alliances. So we are not cheese. We are not cheese that they use us for geopolitical. And sorry to say it, and we are also complicit on this game because we accept the funds from a donor and we know that he is excluding other people in HIV. If you speak that we are all in the same ground. So let's be more global and let's speak global. And I'm not here blaming anyone. We are here to reflect, all of us. All of us. This is a crisis. In MENA region, they close our regional UNAIDS office. You know what they do? You just put at different countries. Morocco, Tunisia, okay, go to West. Egypt, go to Asia. And temporarily, we are not sure if we're gonna continue. And WHO, they have another division. This says, no, Mauritania is not in. You have to work with Iran, Pakistan, and Afghanistan. We have nothing against that. We are all one community, but we are part of this game because we accept. So let's be together. Let's speak globally, at least when it comes to advocacy, to access to treatments. Thank you.
Thank you, Tariq. So, Inad, I forgot you in the first round, and then I will go to Diwan and Cyprian, and I think we will close there.
How long do I have?
Like 1 minute.
Oh, can I have 4? Sorry, hi, my name is Inad. I am from, I'm based in Thailand. I'm from Asia and the Pacific, and my questions are actually not addressed to the speakers. I'd like to thank the presentations from Dr. Jeff, Andy, and Dr. Mubi and Ndoku, but my questions really are for GNP Plus and for everyone here in this room. I have 4, sorry. The first question is, for GNP Plus, how do we, and for everyone in the room, how do we unify the voices from different regions and become a unified global advocacy? Because at the moment we are hearing a lot from Africa, and that's not wrong, but we are losing track on what's happening in MENA, in Asia Pacific, in LAC, although we have a representative from LAC and EECA. As a global network, how do we make sure that we have unified advocacies to discuss the different points? Number 1, sustainability. How do we define sustainability? I think Dr. Nduku has presented that. What is sustainability for us? And right now, from the presentations earlier, we have 3 different kinds of sustainability that we are talking about. Number 1, epidemiological sustainability. We're talking about how do we sustain epidemic control. Number 2, biomedical sustainability. How do we make sure that the medicines or drugs are available? Number 3, we have the public interventions. How do we make sure that the governments are sustainable? But we are not talking about what is the sustainability for an individual PLHIV. For myself, it is sustainable if I am able to access medicine, my treatment, if I am not stigmatized and discriminated, and I can live and die with dignity. That's sustainability for PLHIV like me. But we are not talking about it. We're talking about the sustainability of other agencies, not about PLHIV networks. And I think that's one gap. Second is integration. I think the important question last night is how do you define integration? Integration of community-led interventions is different in Africa, different in Asia, different in MENA, different in Latin America and EECA. And I think it's good to have that kind of strengthened vision of how do we see integrated community-led services in different regions and how can we support that at the country level. The third one is how do we balance global innovations and global changers and community level needs? Thank you, Cedric, because there's a discussion about long-acting PrEP, lenacapavir, we have Cabelet, but there are several needs of the communities that are being left out. For example, the needs of the healthcare providers, the needs of individual people living with HIV. Are we going to leave this out in expense of discussing these innovations at a global level? And the fifth one is, how do we make ourselves the main character in this discussion? Because from the presentations, the main characters are WHO, UNAIDS, technical agencies, the government. We are not highlighting what we can do. We are not highlighting what our capacities are. And I think we have to list them down. These are our capacities. This is what we can do. And we go to the government, we go to UNAIDS, we go to WHO. This is what we can do. You have to put us on the table. We have to make ourselves the main character. We should not discuss this.
Thank you. Yeah. We have the last two questions. I have closed the book for the questions, so we're gonna go to Dio, and then to Cyprian. It's 1 minute maximum.
Thank you very much, moderator. My name's Mtambuka Deo from Rwanda Network of People Living with HIV. One question belongs to Jeff, is about the suppression of men and young people. Still a challenge, according to the numbers that I have seen that you presented to us. What should we do? Thank you. Second, it goes to Dr. Nduku, social contracting strategies. This is something that any network of people living with HIV across African countries, I believe that we can benefit. That's something that we need a strategy. How should we be guided to have a document that sells itself? That's an opportunity that we are looking for to go with, and we need a guidance. Last, it's about a request to the presenters if they can share the presentation documentation then we can at least borrow some ideas that we can sell back home. Thank you. Over.
Thank you so much, Del. Thank you very much. Use your time. So this is the last question.
Thank you so much. My name is Cyprian Komba from Tanzania. I work with the network of youth living with HIV in Tanzania. Mine will be a question, I think, to all presenters and also everyone in the room to reflect on this question. That I was trying to think we need to broaden our advocacy, not only focusing on HIV, AIDS, and so, but we need to make sure that we take it to the bold, to the holistic approach, also advocating for how our government collected taxes and also how do they spend our how do they spend the public finances. Why am I asking this? Because I'm sure that our government, they have money to just support us, but they cannot support us because they always rely on the donors, and we have been all the time advocating for the donors to just support our work, to support our advocacy, to support the HIV responses. I've been asking myself this question several times, that how can you expertise, doctors, people in the room, help us to do that critical analysis to understand how much per country that we do correct, how much do we borrow from outside, and how much do we allocate for us and for other things that are necessary. It happened to our country that they may spend a lot of expenditures to commemorate or to celebrate the memory of Julius Kambarage Nyerere, and then people are dying in the country. This is what is happening. Government are spending funds for those kind of things that they will give them vote for other time to come. But I think now it's a higher time for us for you expert in the room to help us to do that clear analysis to understand how much our country correct, how much do we borrow that and then we spend for unnecessary things, and how much do we allocate for health, and then pin out those things that are necessary, and then try to just move them to the health perspective, that they fund the community perspective, and then we are here to survive, and then we die with dignity, as we said yesterday. Thank you.
Thank you so much. I think I'm going to have problems because I closed the book and then I see one hand. I don't know. So let's do this. We will see how we manage with the responses, and then we can have comments at the end of this. Please, yeah? or maybe we can move on the panel. I have one small request. You have just confirm if you have this book, like the agenda, with you. After this conversation, we're going into the breakout rooms, and as I said in the beginning, we thought we were gonna be like 20 people, but as you can see on the last pages, we are about 70 people. I said it's 50, but I think I made a mistake as well. So what I'm asking you is to go on the page where we have the breakout rooms, to just select where do you want to continue this conversation, in which group do you want to sit. And then when we say we don't want to dictate where you want to sit, we want you to select where you want to sit based on the topics you see in the agenda. So just do that small exercise. Make sure you know, if we say room 1 this way, room 2 this way, you know where you are going. Is that clear for everyone? Maybe you need time to read. I'm going to give, I want to, yeah. Okay, now I'm going to ask again if it's clear. Is it clear for everyone? Still not. 10 seconds, just read. Is it clear for everyone now? Yes. All right, thanks. So after the responses, we're going to move to the breakout rooms. So you want to? Okay. So we're going to, Mumbi is asking to start, and then we go to Nduku, and then we finish by Jeff, because you've been standing for long.
I think mine is, I didn't get any questions in this round, but I just wanted to comment on what I think Inat said around making ourselves the main character. And when he was speaking, it reminded me of what we were talking about with Cedric, a Chinua Achebe proverb, which says, until the story of the hunt is told by the lion, the hunter will always be the hero. And it's been used usually to mean that, until those who are marginalized or oppressed have the opportunity to tell their own stories, the dominant narrative will always be of the one with the upper hand, or the oppressor, or something in those lines. So it's basically me saying, I agree, we need to make sure that we strengthen the voice of the people living with HIV. We need to tell our stories with that strong voice, so that we demonstrate that we have the capacity, we have the know-how, we have the experience to lead the agenda as far as the HIV response going forward is concerned. Thank you.
Thank you very much. I really want to acknowledge Shalik, because really you have articulated, I'm not sure if it has been better articulated. So I will sort of make 2 or 3 comments not in response. I cannot respond on behalf of government. I'm not government, but because I engage closely with, government agencies, I think it's important for me to make some 3 quick comments. The first is that the issues you have raised are the challenges that we are now talking about, because you have a system that was very well funded, a system that wasn't very well funded. And somehow we didn't create the bridges necessary, so that when this time for no money came, we were walking on a bridge. Right now we are trying to create the bridge when the resources are already gone. So if I was to say anything, I think it gives the people in this room some thinking to do. Is it time to talk, collate data, information from healthcare workers around the key things, the priorities, what they could do? Those are some of the things that could come out of this room. The second has to do with the transition of community health workers, of healthcare workers. You heard the comments I said earlier, that even for some of the governments that have resources to transition them, they have to navigate a regularization process, because the employment terms, conditions, and all of those are very diverse, disparate from how governments employs. And even it makes it even more challenging when we talk about our, for instance, countries that have subnational governments, i.e. like Kenya has counties, other countries have provinces. It just even makes that whole a bit challenging. Having said that, as we have said, those are challenges. What comes out of this room with regard to those kinds of comments is critical. With regard to getting support to develop processes to regularize, to retain that capacity. And I think that was the point I was making. So thank you very much. My 3 comments on the questions around what else we need to be talking about: TB, malaria, NCDs. I think I will say that is part of the conversation that needs to be had, because they are suffering the same issues, and whatever resources might be available right now are just as precarious. The faith-based health facilities. I put the faith-based health facilities in my discussion here because I think there are opportunities to leverage faith-based facilities. And I think one of the things I said is we have to start looking at options such as who is willing and able to pay, so that they can also transition to faith-based facilities, to other facilities. How can we develop ventures that subsidize services that are offered by private sector? And what are the options that we have there? How can we develop networks? How can we develop models that build the capacities of those facilities that were crowded out and now need capacity? They could even absorb some of the healthcare workers. But right now, that must be capitation. Yeah, must have some capital, because if there is no capital, it is not going to develop itself. But that is a model that provides opportunities to be able to sustain part of the response. It will not sustain everything. The public sector still must. But right now, it's time to explore those models. And that's what I think what I meant when I said that, we are starting to think about them and, having some proposals on the table. The last is social contracting strategies. That was my last question. And I will say, maybe let me just encourage, if you can go to the Global Prevention Coalition website, look at the social contracting policy brief that was done by Director Generals of NACS, because they come from a government perspective and saying, this is the pathway, if, in countries to be able to figure out or establish opportunities for social contracting, because I think that is the answer to the strategies that you will think about. Because doing a document, as someone said, that this is how it should be done, whatever document is done, if it does not align with public finance management regulations in countries, it will not work, because money will not move if it doesn't align within those laws and regulations. Thank you.
Thank you so much, Jeff, this is the really, are you there?
Yep.
Yes, please go ahead for the, yeah.
I think there was just one last question between that last one question, which was about the viral load suppression amongst children and men being lower, and how to address that or what to do about that. So first, I think as highlighted, the data community suggests that viral load suppression amongst children on treatment and men on treatment lags behind. I think there is, if we look amongst men, actually viral load suppression amongst, older men is not probably the right word, but men, above the age 35 or 40 is actually very high and pretty consistent with viral load suppression amongst women. It's amongst younger men where viral load suppression is a bit lower. Regarding what to do about it, I think I'm probably the wrong person to address that. I think there'll be lots of innovative solutions there and elsewhere, but I think that there are persistent challenges. I know that amongst children, also innovations in treatment, efficacy, and tolerability, I think are helping a lot in that. So we have seen, since some of the media surveys, for example, rapid or a lot of progress in increasing viral expression amongst children thanks to new regimens and early career transition and things.
Thank you so much, Jeff. And this was, I think, it was an excellent discussion. Can I ask you to really help me to thank all the panelists and everyone who was in the room? So I really understand that we are tired, but not really tired, I think. So let's allow ourselves to continue in the agenda, and so that we can take a break early today. So if we break now, it's going to be a short break. It won't be enough. But if we force it a bit, we can have a longer break. And I think that would be a good deal. That's my proposition. And what we can do now, because we have the breakout rooms and then we have the host.
Nairobi, Kenya. Welcome to the People Living with HIV Leadership Summit,
what we can
to be
do
held
is,
in Nairobi
this is
by the
room
National
number 1.
Network of People Living
Those
with
who
HIV,
selected room number 1, can you please raise your hand?
By GNP Plus, and we are excited on behalf of GNP Plus, Sibo and I, to welcome you to this important meeting that will help motivate, catalyze, re-energize our people living with HIV leadership, local to global.
And on behalf of GNP Plus, the global network of people living with HIV, I really would welcome all of you. And really, this week, we're looking forward to
Karibuni, Nairobi, Kenya. Welcome to
Clap 3 times. Okay, so we are going into group work. Hey, it's been an interesting morning. Like, we are listening. Hey, everyone is thinking hard. But let's think in small groups. So you have, each room has a technical lead that will come and do like a short presentation to just guide your conversations. And then you have 4 questions that are sitting with your hosts. So follow your host. And you have a writer in the room. So don't worry about taking notes. There are writers in each room, okay? Hiya, let's go. Room 3, follow Sibo. Room 2, follow Inad. Room 1, stay with me. You can scan to give feedback. You can also scan the whatever that thing, I don't know, that young people use, and then use it. Seasoned people don't want me to say I don't know what it is. Cedric, thank you so much. Oh my God, a whole half a day, you're done.